better. So, so that's we're going to look at that study right now, and so. And I don't know what, so you know, I'll start at the beginning, and then you all can, a lot of different levels. If I say something that you know all about, just bear with me. But the metrics of interest, what we're interested in measuring on this particular study are the EEG brain voltages. You know, EEG is a voltage on the cortex, so we keep the word brain with a grain of salt. We have to measure it through the scalp, as you all know. And what we like to focus on the alpha frequency, 8 to 12 hertz. Because it's such a nice big peak, it's very reliable. Beta is sometimes contaminated with muscle. Theta is also reliable, but it's not as big of a peak. And delta can also be confounded by motion and such. You know, delta is, you know, when you're rocking, that gives a delta motion, so we have to be careful. So alpha is the most reliable. So if we can do everything we need in the alpha band, then life is good. And we're also going to look at EEG connectivity, again, in the alpha band, and that's the coherence. And coherence is a good marker of connectivity. It also, just so you know, it's not just brain connectivity. It can also be connectivity due to brain function, but it can also be connectivity due to some structure. So we have to keep that in mind. And the second thing we want to measure is the P300 amplitude. So a quick refresher on that one. So here we are, as you all know, this is the Wavi headset, and it's the 1020 montage, pretty standard EEG montage, and then it produces the brain wave. It reads the brain waves coming off of the scalp. And here you can see the nice alpha peaks, and you all are on my screen, so I'm gonna get you off here. You can see all the alpha peaks here, and they're very strong in the occipital parietal area, and there's not many alpha peaks here in the central and the frontal areas. So that's typical. Okay, so you see this nice ocean waves in the back, and not many ocean waves in the front, and that's a typical EEG wave, and we'll go into that. And then for those who don't know, I don't know who's familiar with the P300. I'm assuming you are, but if you're not, this is what the P300 is doing. We're going to give the brain a task. In this case, we have a common sound tone and a rare tone. When we give the brain a task, we're going to measure the voltage response to that task. And this is a cognitive task, and it takes about 300 milliseconds for the brain to say, wait a minute, I heard a different sound, signals to the rest of the brain to do something. So this is the P300 task here. Oops. Uh-oh. Did you all hear the beep?
Yes, I hear it.
Okay. That's all we're doing. Just when it hears the high beep, the brain lights up. Now there's it takes about 100 milliseconds for the high and the low tone to light up. That's the N100, but it takes 300 milliseconds for the brain to distinguish something different. And that's a really powerful metric we've discovered. It's a measure of cognitive resources. So it's like the brain's battery. And then we can also do the speed of that classification. What we find is the classification speed doesn't matter for concussion. The brain, whether it's concussed or not, has the same speed, which surprised me when we first saw it, because the reaction time is really delayed with concussion, as a lot of you know. But the brain speed doesn't change. It changes with Alzheimer's, it changes with depression, it changes with other markers. But it's the brain voltage, it's the P300 voltage that really declines when there's concussion. And there should be no surprise to anybody. The cognitive resources are diminished when people are concussed. That's, in some sense, what a concussion is. So the Wavi reports that those who are using Wavi will get look like this. And this is the front page dashboard. And things that are relevant to concussion we'll find is the reaction time. Reaction time declines after concussion. And then the peak frequency is something to keep your eyes on. Peak frequency is an interesting one. We have a white paper on that. That's a mark of a person. It's hereditary. So, and it stays fairly stable. It declines as you get older, but not a lot. So if the peak frequency changes from a baseline, that's a significant deviation from a person's marker. And then we have the audio P300 delay, we talked about the speed. And then you'll see the P300 voltage. And this is the thing that declines. This is pre-post concussion right here. The peak frequency you see isn't changing a lot after concussion, which is interesting. And so that's the Waveform dashboard, the front page. But the things we want to be careful about are the make sure the metrics make sense. So everybody likes the topos on the front page of the report, and this is the P300 voltage map, heat map, and you can see that for this particular person at baseline, this is where the voltage was predominant, and after concussion, the voltage was very diminished. Common thing that we see. I don't know this patient's pathology, but this, when I see this, where there's no response on the left side, it's very curious what's going on there, but that's a different subject. I just noticed when I put the slides together this morning, this is very odd. Usually we look for left-right symmetry. But also this is the voltage map pre-post. Purple is baseline, red is what the brain was doing after concussion. And this is what I told you about. This first peak here is the N100. This means the brain heard it. And then the second peak, we don't know what that means. That's the P200. Got it. Sorry, P200. We think that's an early Alzheimer's marker, but we haven't really explored it enough. So ignore that one. But this is the one we really want to focus. This peak right here near the dashed line, that's the P300. And that's the thing you can see goes away after concussion or gets diminished. Okay, so it's always good to review the raw waves to make sure it's a good test, make sure it makes sense. Those people like going straight for the topos. Next thing we're going to look at on the reports are the alpha, peak frequency. On the occipital region, we get this nice peak, and we can assign a frequency to it when we get a nice peak. And the front, you can see, is diminished. We don't get as many nice alpha, don't get a nice alpha peak. So sometimes it's harder to measure a frequency. As you can see here, it's kind of a slope. So it's hard to say what the alpha frequency is. In this case, we give it a star if it's hard to tell what it is. So it's always good to review these peaks to make sure they make sense. And those, none of you have this except not even Jim yet. On the new release of the software, we put in a topo for the alpha to let you know where the alpha peaks are strongest. And this is a normal alpha topo, central parietal. Okay, heat map. So final thing we're going to really key in on is coherence here, connectivity. And we can do coherence in 3 ways on the Waveform report. First way is you can review the screen and to touch a site. Here, I touched the site on the O1, and you can see where the connections are for the O1 site. Or you can do a Z-score coherence, which is, it shows you all the connections that are over 1 sigma. Or I'm sorry, in this case, over 2 sigma. So the dark red lines are 3 sigma out of normal. And so this particular person, which we'll find later, is a prolonged concussion, very connected from front to back, and 3 sigma more than normal. So, and this is a common thing we'll see for prolonged concussion, not for acute concussion. So we interpret this as the brain reorganizing itself, trying to work around the damaged areas. And finally, if you Waveform reports, if you see coherence looks like this, there's noise. Sometimes it's very rare, but when it does happen, it's spaghetti. It makes no sense. So coherence is susceptible to noise, to motion artifacts. So anyway, so now let's go through what we see, what we've seen on the simple concussion, and we'll make a lot of time here for questions. So make sure you have your notes ready, because I saved a lot of time for discussion, because you all come from different levels of knowledge of this system. So after a concussion, this is just a typical sports concussion. So the person just had a baseline, which is the blue. And then after concussion, the person diminished. This is 48 hours after the concussion. You see the P300 go away, diminished by a factor of 2 or more. And then when the person was cleared to play by the standard methods, the P300 voltage was back to within a normal range for this person. Now, there is no normal range that because everybody's different, so we have to be careful with that. Really, this is most powerful of self-comparison. Test, retest. Who are you? Find out who you are, and then track the person's voltage over an event. So that's a case of a simple concussion. What we don't see in the simple concussion is we don't see the changes in the alpha amplitude. So this is the alpha amplitude for this person at baseline. This is the alpha amplitude after concussion. Ignore the X, that means the person who administered the test didn't connect this site very well. And this is the alpha topo after concussion. You see really no difference after return to play, sorry. So there's no difference. So the alpha amplitude does not shift for simple concussion. We just don't see it. Same with coherence. This is the coherence before, this is coherence after concussion, and this is coherence at return to play. We don't see a lot of difference in connectivity from a simple concussion. However, we might see a slight increase of connectivity. So after this person was cleared to play by the impact test and by the standard symptom resolution and all of that, there still is a little bit of maybe residual stuff going on with the coherence. Now, in about 40% of the time, we see the symptoms go away. They are cleared by the standard performance, impact, or trail making, or whatever. And about 40% of the time, we see that the P300 has yet to recover. And this has also been seen with MRI and SPECT scans, PET scans, where the brain recovers slower, but it compensates. So symptoms allow it to perform normally, but it hasn't quite recovered. So now now we do the whole trajectory from simple all the way to prolonged. The PPCS people who just don't recover, they're years removed after concussion. It can be the same type of impact, and still some people just don't get better. So this is a very, very interesting slide here. If you look at the frontal alpha frequency, the reference group, baseline, no different. Acute concussion, no different. Acute return to play, no different in the alpha frequency or alpha amplitude. But prolonged concussion group, they definitely have this strange frontal alpha shift, which we'll talk about in a bit. Another thing we see is this increased connectivity. So we don't see a big change, significant change from the baseline to acute concussion. We may see some increased connectivity at return to play, but this prolonged group has dramatically increased connectivity. And this graph is the number of lines over 2 sigma. So the average for prolonged case, they have 12 lines over 2 sigma. So very, very connected. And these are usually those long distance connections. And here's something else that comes on the WAVI report. You'll see the non-PPCS. This is a typical alpha topo that one should expect. After the prolonged group has this frontal dominance. It's so common. No, we don't really know what it means. At the last slide, we'll talk about how we're trying to tease that out, but it's pathological. So a lot of you that are working on interventions, that whether it's Clark or the other performance people, the yoga intervention, is that correct? It'd be really good to focus on a group like this that has a pathology, and can you shift the pathology back to normal? Because this is abnormal. And I'd really like to see, in fact, I put feelers out to some of the Clark people using the Clark product. Can you shift it back? So Chris, part of the problem with the study you were doing, in my view, is that you had a lot of normals, you had a very strong performers. And so if you have somebody like this, there's nowhere to go. But we really want to focus your product on these abnormal people.
So pay more attention to that frontal alpha.
Yeah, and the over connectivity, right?
Okay.
Because another thing that we see here is this is normal, non-PCS, okay? And here we see most of the connections are from occipital. I pushed the O1 on there, O2, sorry. So most connections that you expect to see are strong connections to nearest neighbors, okay? This is a different scale than the one on the right, okay? This is 0 to 1. 1 is maximum connectivity, 0 is no connectivity. So we see a lot of red connections between nearest neighbors, which one would expect. But after on prolonged concussion people, the biggest connections are these long ones, and the close connections kind of went away. Very curious. So the brain is definitely reorganizing itself on these prolonged cases. If we do a Z-score on this is a different patient. But if we do a Z-score, we see similar things, what I showed you. So I think the Z-score is the easiest because you can immediately see everywhere that the connections are out of normal by definition. So this is a prolonged concussion case, what it looks like when there's resolution, symptom resolution. And the red was the first session, and the green in this case was the second session. So diminished P300 voltage, in this case it's almost a 0, which is crazy. And then a very strong, this scale screwed up, it's supposed to be positive down. Gotta yell at Francesca. So anyway, so the P300 down here is really strong at recovery. So the cognitive resources came back, the batteries recharged, person's symptoms went away, person went on about their life, which is good to see. So the PPCS, what we see here is we see a lot of frontal activity in this particular person. This person also had some occipital activity, but no parietal activity in the alpha. So it's kind of an odd topo, a lot of connections. And then when their symptoms resolved and they were able to get back to life, the alpha went back to where it was supposed to, and there's not as many connections. So the brain definitely reorganized and settled down, and that was good to see someone heal. In the Spark clinic we're working at, a lot of people just don't get better. It takes years and years. It's hard to see. And this is typically what we see there. We see the P300 voltage starts low and stays low. As you can see here, if you compare the last slide to this slide, that's a clear P300 peak. That's what you look for. And here, there's nothing emerges, just noise. So there's no P300. So the cognitive resources are in the toilet for this person. Now, this is very curious that we see the frontal alpha, but the connectivity is low on the first time the person came in. Person came back and they were doing worse. And we see this frontal really getting enhanced, and we start to see all these connections. So I want to see what this person looks like when they recover, but they haven't recovered yet. And some of these people never do. They need help. I mean, that's when I look hundreds of these files that they send me, and all I say every time is these people need help. They come in year after year, and this looks like this all the time. It's kind of hard to see, and there's really no, what I see, no, for a lot of them, there's no great intervention. You just wait it out, and that's a problem. So what does this all mean here? We don't know. And that's the point. We don't know. We're trying. We know this is abnormal. You know, when you see this, it's abnormal. And you see something abnormal, it's good to try different interventions to see if one can change it. But no one. This is a new field, really, right? Prolonged concussion. We're just starting to look at these phenotypes, and we're starting to try to link some of our findings with the phenotypes. So this is the frontal alpha magnitude folks, and they're very enhanced. But who are they? You know, what can we do for them? And so we try to sort it out based on the headache, cognition, the ocular issues, the mood, sleep, neck pain, and vestibular issues. So we sort out into those 1, 2, 3, 4, 5, 6 phenotypes. And we see that the headache is significantly, this is significant compared to the vestibular. So if someone has a frontal alpha, maybe we should focus on headache, cognition, or ocular issues before the neck pain and vestibular issues. But again, I really am interested to know who these people are, because it's a very strong subset. Something I didn't talk about a lot is also the alpha frequency slows on the PPCS group. It's not as dramatic as the magnitude, right? That's really dramatic change. But there is a subset of people who have low frequency, and we're trying to correlate that, and we find that those kind of correlate with the neck pain folks. Now, in our last pain study, we found that it's one of the markers of pain is a low frontal frequency. So the alpha moves more towards the theta, and that's a marker of pain. So that's a really interesting finding if that persists. So people who have diminished frequency, they may just need neck massage or something. That may be their prolonged concussion issue. It may not be anything more than that. So that could be an interesting study. So that's where we are. So it's pretty simple. We try to keep WAVI simple. So we see the P300 amplitude is reduced in both simple and prolonged cases. No surprise there. But the alpha amplitude tends to move forward in the prolonged case, does not in the simple case, which is a surprising find. The alpha frontal frequency tends to decrease in prolonged, does not in simple. The long distance coherence tends to increase in prolonged, not in simple. So the prolonged has a unique signature, three unique signatures from the simple concussion case. So now the next question is, can we use this information to investigate phenotypes? And for a lot of your end, which is not what we do, but from a lot of your end, can we use this information to investigate outcomes? So do different type of people do better on Nupinex than others? Can we help guide the prescriptions? The yoga people, if we go back to the, there is some phenotypes we're trying to, and there's some other ones I haven't shown you, but mood and sleep. We're trying to correlate some of these markers to mood and sleep. Poor mood, it's how much a prolonged issue is mood, right? So if the brain is depressed, it could start to unravel in some sense. So there we go. And that's all. It's pretty simple. Try to keep it simple here at WAVI. So I'll stop sharing my screen and bring you all back up.
Questions? Who has questions?
Hey, Craig.
Hey, everybody. Hey, Dave, Doc. Good seeing you. Sorry I was a little late.
No worries.
Yeah,
My question,
too fast or
my
too slow?
question,
Yep, go ahead, Russ.
hi, it's around the chronic condition. Obviously, our wellness challenge, our brain renewal study that we're doing, that you're aware of, is going to be looking at chronic markers.
Mhm.
So just wanting to know the degree to which this is associated with acute, or in our cases, some of these concussions are years old. So
Yeah, so all of these would be relevant to your study: the connectivity, the alpha frequency, the alpha amplitude shift, and the P300 diminishment. So I just keep the study simple, all those four. And so are those out of normal?
okay.
So, yeah, and the acute phase is it's very these are different types of concussion. There's something different going on, right? Clearly, with the prolonged. So we call it all concussion, but we're show from here it's not all concussion. These are different things happening. We don't know what they are, right? Is it metabolic? Is it
Potentially.
Yeah. Is it mood? Is it depression? Is it?
Okay.
Yeah.
David, what was your metric for determining the prolonged versus just a regular acute concussion? Was there a time frame?
I believe the prolonged is 3 months, something
Okay.
like that. It says in there's a pretty standard for prolonged.
Okay.
But, it's arbitrary, right?
Yeah.
Yeah.
Okay.
But
Dave,
most of these people I showed you are years.
Yeah.
They started 3 months, and then their symptoms didn't go away, and then we've had them for 2-3 years now, and it looks the same. This frontal, the symptoms are there. So a lot of these, we probably have 200 patients now in our study,
Jesus.
and maybe even more, and they just look the same year after year after year.
And
It's awful.
is there treatment being done? I mean, of what kind of, is there any documentation of treatment being done? And I was really curious, with Clark there, I mean, that's like you brought them in. I mean, this would make sense to try to grab those 200 that have that that frontal issue going on and try to, I mean, find a solution, because I mean, what's the point of studying all these brains and if we can't help people, right? I mean, this is the key.
Yeah, and so this is what's interesting about this to me. It's an unsolved problem, right? What do people do? There's no standard for treating. I don't think, my experience, I'm just a physicist, by the way, okay?
Right.
And medicine is so hard. My experience, they don't do anything.
Yeah.
They don't go home and, try to get some sleep, no one knows what to do. And there's a big debate, is it metabolic issue? Do they, and I think in maybe 20% of the things that I see, we can kind of see the neck pain marker, which I didn't show you, but it's on one of those reports if you want to see it. But about 10-20% of the time I see neck pain, I say, guys, just go give them a freaking massage. This all might go away. And it does in a lot of those cases. This happened to one high profile running back. Symptoms went away. So it wasn't, what is a concussion? The problem is there's no such thing as a concussion. It's all different. So that's it. It's an interesting problem, but no one has solved it.
To add to that, I have a new neurologist that's coming onto our team, who's been looking at this stuff now for several weeks. And again, I told him, look, I don't want just you to look at the waves. I need you to really focus on the P300 and all this other stuff that's going on. And he's really wrapping his mind around this. He would love to have been on this meeting, and that's why I'm glad it's being recorded. But he is going to dive into this and do his best to really figure this out and start. He's going to start doing it with his patients. He's not a current client, but he's also going to start handling all of our reads that we're doing at clinics, in Nevada and across the country. So I'm pretty excited about this, and I can't wait for him to watch this. And we do have a large group that's looking at this strictly from a personal injury standpoint as well. So yeah, this is great timing on all of this, I have to say.
Right, and this is a good, people like that. The fun, what Wavi likes is that they can help the patients right away, right? You can look at things, but then research outcomes. Who, how do you make these people better? And that's the hard thing. But then anything that works, it's great to publish it. We write papers together. The data I showed you on the prolonged, we submitted publication with that doc just last week, and so I like that, because you all are actually doing interesting things that are not. It's research, right? You're on the forefront of this thing, trying to get ahead of this problem. So we need to publish something with Clark, but really want to link you with the Spark folks.
That would be great.
I already did try to link you with them, but I'll do it again.
Okay, fantastic.
We're going to be doing some long-term hyperbaric oxygen therapy studies. And are you aware of any successes in that area in terms of treatment?
Yeah, we've had some case studies on that. And my instinct is, on all these things, whatever we do, it's probably one of these phenotypes that you'll affect, not everything. So people try to throw all concussion people into the same pot. And I think what you'll find is that some will respond and some won't, because again, there's a lot of different phenotypes for concussion. Now, a lot of people we work with have had some success with the therapy. I can send you some case studies, but the hard studies to do, right? Because you have to have a placebo group and all of that. So you can do a beta study to see, is there group differences between the hyperbaric group and the non-hyperbaric group, which is what we're doing with our phenotype study. But then to actually do a post-beta study is hard to get placebos and such. So again,
well, the question is then, does the beta group have to have had a concussion, and how close to the time frame? Because I think we can do that. And their question is going to be how accurate the Wavi is, and how is it calibrated and so on. So
that wouldn't be that's an easy question to answer. We passed all of our there's standards for EEG, the EEG standards, and 60601-26. So, you know, an EEG is an EEG. So it's not calibrated, it just measures the voltage, and it's been, it meets the standards. If that makes sense. There's no further calibration needed.
Good.
It's not magic.
Well,
We're just we're like a scale, right? So
well, this is an area we want to look at very carefully, obviously, given who we're dealing with. So
yeah, and the accuracy then is really not the issue is the how do you construct the study and measure the changes. That's really that's the hard part. The accuracy, the hard part's easy. You know, we just give you the numbers.
So David, question on symptoms. When we talk about long-term concussion and the sometimes inability to relate symptoms back to that, you know, where we see maybe some kind of clinical depression 6, 7, 8, 10 years later, people are not able to link that connection. In your experience with the study, I guess I'm wondering, do you see any type of treatment where somebody who, again, this may be sort of a dumb question, but somebody who's had long-term symptoms, long-term concussion symptoms, is there anything out there that folks have done that has pulled them out of that state and put them back on a more healthy road? Is there anything out there?
Just speaking from my experience, I haven't been impressed by anything yet.
Okay.
Yeah, I'm shocked. I'm shocked at how long it takes these people. I'm shocked that there's just not much they can do. The patients get frustrated. We need to, that makes it a real opportunity, right? For example, except the neck pain, obviously, you know, that goes right away. It's like, dang, that's all I had. But the metabolic issues, really interesting. The metabolic cascade, where, you know, Frank could tell you all about this, our Dr. Palermo, our medical director, but you know, the brain gets all revved up right after concussion, the norepinephrine is going crazy, and then it crashes, and sometimes it just never gets its energy back. It gets this cascade where it just never gets its energy back. And so some people will claim it's all metabolic, just work on the metabolic issues.
Mm-hmm.
But nobody really knows, right?
Can a concussion affect the brain's ability to absorb nutrients?
Yeah, all of the above. Yeah.
Okay.
Hormones, right? You get the hormone imbalance, and then now we got issues. Blood flow. There was a lot of talk about blood flow. We mentioned that in our paper. So yeah, that would be. Yeah, it's all above. The problem is it's such a complex organism, right? It's not the brain. It's so complex. It's my opinion. It's not. And the experts agree. It's not one thing. We call it concussion, but it's not. It's
right.
You get hit in the head and something happens. What is the thing that happens? That's what we have to figure out. And most people most people from our sports studies get better pretty quickly. You know, a week, the symptoms are gone. In 2 weeks, all of the standard protocols clear them to play. We think that's accurate from our studies in 40% of the cases. Sorry, 60%, but the other 40 probably need another week or two, in my opinion. But that's that's most concussions are not as bad as people make it out to be. It's just these long.
What about the susceptibility to reconcuss?
Yeah, that's a big deal. That's a really big deal. And a lot of that, in my opinion, is coming from people just getting back in before the brain is healed. The performance is great. They're back in. I feel great. My symptoms are gone. But if the reaction voltage is still low, that's not good, in my opinion. You know, do no harm. I had arguments with some of the world's experts in this, and they say, well, until you know that you're doing harm, you put them back in. I say, no, you know, don't put them back in until they're normal. But I lost the argument to the Seattle Seahawk trainer, because he said he also is a physician for some inner city schools. And he said he puts those kids back to play as soon as possible because he knows there's more risk for gang violence than there is that they need the football. So you know, he's just doing a risk factor analysis, and so that's appropriate. But And if you're making $10 million a game or whatever, and your family depends upon it, well, that's a different issue. But you know, my kid would not get back into play until the P300 is back to normal.
Right.
Absolutely not ever. But then, you know, I do think it's, my opinion is, it's a little, there's too much hype around simple concussion. I think most people do fine. You know,
So we're looking at two other factors. One is using the phonar MRI, and I don't want to monopolize the conversation, but which is able to show injury into the brainstem and neck and the cervical spine. And then the second is we're waiting to do a study that is going to look at the microRNA markers in the blood that form as a result of a concussion and persist years subsequent to it. And we'd love to see if we can get that that test fully. It's about 85% of the way there. We need to complete the study, and that's why I've been working with the NFL alumni. But beyond that, we need to also be able to differentiate PTSD from TBI so that people who have served are able to be careful, properly treated.
Yeah, that's an interesting one. Yeah, and all of these should probably be, be really interesting to correlate the WAVI with all of those markers.
Yeah.
Particularly the brainstem one, because is there a phenotype there? That's definitely a different injury than the metabolic one.
Yeah.
But
well, and is there a different microRNA marker that can diminish? Can we track it like a, blood sugar number to the point where we can see a metabolic baseline for the return to play?
Yeah, I don't know enough about that. I know that you could probably answer. We'll talk offline on that. The brain-blood barrier issues. Do you have to go into the spinal fluid to get that marker, et cetera, et cetera. But
is the preseason baseline scan more valuable to the potential patient, or is it more valuable to the practitioner treating the patient? And I'm asking because, it seems reasonable that one can surmise statistically that a young athlete ought to look a certain way when they're in a healthy brain state versus when they have a significant concussion. But what we're trying to do is convince people to enter into that baseline pre-screening or preseason screening mindset. And my question there is just, again, is that more value for the patient or is that more value for the practitioner?
Yeah, I wouldn't separate the two.
Yeah, they go together.
They go together.
Yeah,
but
fair enough.
Yeah, I think it's essential to know thyself. So what does a healthy brain look like? We have our normals, but everybody's normal till you get to know them. There's a book called that. So I'm not a big fan of the normals. I'm a big fan of getting to know the person and then look for changes. And there's certain things that don't change over your lifetime, like your frontal or like your alpha peak frequency, or they don't change that much. Your P300 voltage is a mark of a person, and the speed. Speed is really a mark of a person. So if those things decline out of a normal decline, that's why our normals are based on what change from baseline you should expect. If those things change, then that's something happened.
Mm-hmm.
So I'm
Well,
a big
but
fan.
that really makes a
world,
case. That makes a case for the baseline.
Yeah, that's a baseline.
You made the case.
Yeah.
It's all individualized, personalized. So if you don't have a baseline, you don't really have a reference point.
But you can still use it, and that's most of our cases are there's no baseline, because in the real world people don't get reimbursed. EEG is reimbursable, right, Craig? But people don't get reimbursed unless there's an event. So you don't get reimbursed to get a sports physical. So so the world we live in, we have to deal with the change from after the event. So on our prolonged concussion people, we look at the event, and then we look for improvement back to normal, whether it's the voltage improving, whether it's the moving back to the occipital regions, whether it's the frequency increasing or connectivity decreasing. So so it's kind of concussion or baseline in reverse, right? So we assume that they're going to move in a direction and see if they do. And I think that's with the Clark pharmaceutical study, that's perfect for that, right? Find someone who's out of normal, then that was my original comment to you all. Look at people that are out of normal and then track them to see what happens if they can get back to.
Yeah,
Yeah.
kind of in that same
Yeah,
vein, talking about coherence earlier. I'm Brett Serene with Clark Bioscience. We're trying to understand as far as in what signifies a change, and so you have a threshold set on coherence as to when it shows up as being a significant change. But as you start to rewire the brain and things start to come back online, some of these changes aren't magnitudes different. So how are you determining what signifies a significant change?
Well, that the one plot I showed you, which is 2 sigma out of normal, that's by definition out of normal. Now you're out of normal, right? You're at 2 sigma, 2 and 3 sigma. So so I would focus on those edge cases, which a lot of the PPCS people have those. So they are abnormal by definition. And so I'd focus on that and then look at changes back to normal. Otherwise, you can end up reading tea leaves, if that makes sense.
So you say 2 sigma out of normal. So I think threshold 0.4 is I think what you have standards.
No, you're thinking, yeah, so I apologize. There's, in the report, as I pointed out, you can measure the actual raw coherence from 0 to 1, or you can focus on the norm compared to the normal ranges. So, and so you can just look at the, from everything above 2 sigma. So you could have a connection of 0.1, and that's 2 sigma out of normal. I think 0.2 from O1 to F1 would be 3 sigma out of normal, even though 0.2 is a very small connectivity. But from that front to back region, it's it just the brain doesn't connect that way.
Are these ranges available as far as in like what's the normal range for what you should be seeing in coherence for alpha, I guess?
Yeah, and that again is what that Z-score plot is.
Okay.
Yeah, and I think that's really relevant for you all. Otherwise, you don't know. Is 0.1 big? Is 0.2 big? Well, is 1. It just depends on the location of the brain.
Okay.
So and so you can say if you have your control group, you can compare. There's 2 ways to do it. You can use our Z-scores or just the Excel table and get a control group and look for differences.
Okay.
We've already done that for you on the Z-scores, but if you're doing a real research project that you want to publish, you may want to use our reference group or something, and then download the Excel of all the coherences and then compare to normal. Look for differences between your group and the normal group. That make sense?
A little bit. I might have to ask for clarification on some of those things offline.
Yeah, because sometimes you've all gotten in trouble looking at the small coherences like 0.05 to 0.1. You said it doubled, but it didn't because it's still not significant. Yeah, so coherence you can get into trouble because there's so many. There's 200 connections. So if you're not careful, you can read any. And a lot of there are companies that do that. They promote reading tea leaves and they get kind of bad reputations.
Well, kind of in another question to that is you're saying that you're seeing connectivity from the back to the front and the brain rewiring, and you're saying that that's not necessarily ideal because you want to see an increase in like very short, I guess 1 to just its neighbors. But I would also argue that the rewiring is a good thing too, because your brain is starting to.
Yeah, that's right. Yeah, so I wouldn't use the word ideal. I would say not out of normal. Okay, so if I said not ideal, that would be a mistake on my part. It's not normal. Now, does a permanent rewiring, is it a good thing or a bad thing? Well, I don't know, but the ones who have symptoms have this high connectivity. And the ones whose symptoms go away, the connectivity settles down, except in some cases. There are some people who, which you've worked with, you've had great success. We can't say the name because of the privacy, but she was gunshot wound to the front of her head, right? And it was, frontal lobe was gone. And so the reconnectivity stayed, and it had to, right? Because that part of the brain had to talk to somebody because it was so damaged.
Sure.
So, and she's doing much better now, and that connectivity stayed. And And yeah, but she was made in her issue. Had that slowing frequency, right? The frontal frequency was too slow. It was just so everywhere. So all her alpha moved into the theta. And I think you all got her back into the alpha.
Yes.
I believe. And that's a big deal. So yeah.
And I think this is so important too, because Dr. Salinas, Rachel, and I see patients when they're suicidal, incredibly depressed, PTSD. And so working as a team is so important. And we're out of Chicago, so we are in the suburbs in Illinois. And the team approach isn't so prevalent. They send them to psych, just expecting this change, but top-down approach, they're so confused and frustrated and wanting this change and then in and out of the hospital for suicidal ideation because their lives have changed so much. So that's why we got certified in Kundalini Yoga, which is meditation, because all the research in trauma is the bottom-up approach. And so everything you're talking about with research, we do as well in regards to dissertations. And now that our field in psychology is really focusing on those pieces, which is so important. And that's why we networked with Steve, and that's why we're here. So we're really excited to be here working as a team to really see these vast changes. And so part of the healing process, we know with concussion, with the healing journey, it takes 7 to 10 days. So what if we added this piece? And again, us being therapists, and also, and Melissa and I are clinical psychologists, and we work closely with neuropsychologists because we also do the testing. But you know, that takes 8 hours. You don't have time to do that within all those pieces. So WAVI is a big part of that. So yeah, so we're super excited.
I'd love to
about
get
it.
to some of the pre-post data on the anxiety, depression, or suicidal thoughts. I could show you a plot from our pain rehab study, which I don't have handy. I have to go find it, but where we can use artificial intelligence to classify people. And so I'd love to do that study with you all. And yeah, that's a really fun data set that you're collecting. So, but classify them, according to your clinical evaluation, and then look for changes. That's a really fun study. Let's go do it.
Absolutely.
Get baselines on all your people. Now your baseline, again, caveat, it's not the same baseline that Steve was talking about. This is a baseline on people when they're in their condition. And then the post would be an improvement, as opposed to someone who baseline they're at their best, presumably concussion is not improvement. So, but yeah, let's baseline them all. That'd be really interesting.
So I'm an athletic trainer in private practice, and I've got to run to a patient here in a few minutes, but I did want to add on there, I've seen several post-concussive individuals that have had long-term symptoms for several months, years, and I can't necessarily explain why it helps, but I've seen dry needling to a lot of the fascial lines tend to help with symptom alleviation, whether that's a systemic metabolic effect as a result of the dry needling, or it's a tissue movement problem that's maintaining some sort of amygdala stimulation toward bad postures, bad movement, whatever. I have seen dry needling be very effective as a overall movement and tissue quality treatment tool.
That'd be great to do a phenotype on that, right? Can we identify the people who, my instinct is maybe that's the frontal slowing people, but it'd be interesting to do a phenotype on that.
There was a New York Times article last week about the glial system within the body and how it's really being discovered, the extent to which it's a secondary communication layer. And you're obviously stimulating that with the dry needling. So I think just to look in that direction, that's a part of what's going on, I would imagine.
Absolutely. Yep.
My instinct is one size won't fits all, that everybody will respond differently. Problem with this, dry needling work on some people and we need to get that study. And if it doesn't work on other people, we'll say, oh, it doesn't work. Well, no, that's not true. We're dealing with different things, right? Yeah, so yeah, I'd love to see that. So you guys have great studies, right? I mean, come on, let's do them. You're keeping busy. Keep my students busy.
I got a quick comment, just kind of off this topic, and I think I might have put this in an email to you, Jim and Austin, but I know our neurologist is asking, so when they're reading, the raw waves and just ruling out epilepsy and seizures and all that, to be able to have our system record a video of the individual to really catch these artifacts, if they scratch their head or somebody walks in the door, they said that would be extremely helpful because there's some that almost look like episodes. So it would be an easy feature, in my opinion, to add, but I'm not a development guy. I see Jim smiling over there. So what we may end up doing just as a workaround is actually putting a video in place and basically hitting start at the same time, just so that our neurologist has a little more security in those artifacts. Make sense?
Yeah.
Well, yes and no. Got to keep in mind who we are. We're the quick snapshot.
Yep.
And so the raw waves get a lot of information. A lot of neurologists can just read the raw waves and get information out. If they want to do a deeper dive into epilepsy, they probably should use a different system. Get a $200,000 system that does all of that. So if they see anything that looks intriguing and they want to bring the patient in and do it, they probably need to do that.
Hey, Craig,
Yeah.
we're gonna develop up a $200,000 system for you. We'll be working on that.
But you can video. If he'd be happy with the video, then just do that. That might be
Yeah.
I will say I do a face recording during the P300 trial on all of my patients. I just have an iPad that sits right above the laptop and records their face and eye movements.
That's a good
throughout
workaround.
the test.
Yeah.
That way I can scroll back through if there's any sort of artifact right there.
Good reason to buy 20 iPads, I guess.
Yeah.
But in reality, we can see, you can see motion. Most neurologists can tell motion and eye movement versus a seizure.
Yeah.
That's easy to see.
And they are, it's just a suggestion. And so, but you make a good point. That's, hey, order the next test and we'll send them to you for the more important study.
Hey, Craig, just FYI, I'm sure we could probably get it done for you for about 150.
Well, yeah, I have a check ready to go. I'm just loaded with money. So
Yeah, you know me, I'm just trying to save you a buck. Okay, well, we're coming up on a full hour here. I did say that we would try to keep it to under an hour. So unless people are raring to continue, I don't want to be presumptuous, but I certainly appreciate everybody being able to join us in not exactly last minute, but especially for the time of week. Really great to have everybody a part of this. And any last minute questions that you have swimming around your heads, please feel free to email them to me and we'll get those out to the right party, Dr. Oakley or Jim or whoever. And we can take it from there. As I said at the beginning, I would like to do this here and there. I don't know exactly what that timing looks like, but I think we should do something sort of consistent. Maybe it's once a month, maybe it's every other month. I don't know, but it would be good to get together like this. And so again, appreciate you being here. Happy Thanksgiving to everybody. And from here, I guess we'll go ahead and sign off. And we will talk to you all very soon.
Awesome. Thanks for putting it together,
All right.
Steve.
last question,
very
is the
much.
slideshow going to get sent along with this recording?
Sure.
We can work that out. Sure.
Great.
Yeah,
That would be
absolutely.
great.
And thank you, David, for the presentation.
Yeah.
Thanks, Dr. Oakley. Appreciate it.
Yeah,
Thanks, you guys.
thank you, David.
Bye-bye.
All right. See y'all.
Bye. Nice to meet everyone.
Nice to meet you too.
Happy Thanksgiving.
Happy Thanksgiving.
Bye.